Our moderator for this particular panel is Richard Miltenberger. Richard is a member of our planning committee for the Healthcare Forum. In addition, he is the CEO for Inner West Health, and he also serves as the Vice President for Government Relations on the Montana Chamber Board. He will introduce the speakers.
Thank you, Tanya. I'm the guy who was trying to sneak in late. You may remember who Tanya called out when I walked in earlier. My name again, Richard Miltenberger. I'm on the board of the Montana Chamber, and I'm looking forward to this. I hope all of you are as well. We've got a lot going on in healthcare. A lot of it, all the conversation, all the air in the room seems to be taken up by what's happening in Washington, but there's a lot that has been done and a lot that can be done right here in Montana. One of the things that is really wonderful about Montana, our legislature meets every 2 years for 90 days, so we have a citizen legislature. I think it was Webb Brown one day who told me that he was hoping that instead it would meet 2 days every 90 years instead of two. But anyhow, but one of the things that, and I look back at my home state, I'm also originally from the South, 17 years here in Montana, but my home state of Louisiana, I have a cousin, Charlie Lancaster. He may still be in the legislature, there's no term limits there, but when I grew up, Charlie was in the legislature, and I remember asking my mom what Charlie did, my cousin, what's he do for a living? Oh, he's a politician. That's what he did. That was his career. And he literally, the Montana legislature meets about every other month, and people quit their day job, and 200 people are legislators in the state. And I think you could probably quit your day job in Montana, but you'd be living in a van down by the river on the legislators' pay. But it does put us, it's kind of a good thing. I think it's largely a good thing, but it does put us a little bit of a handicap because Congress is always doing stuff. We have this congressional season coming up. There could be changes to the Affordable Care Act. I'm no expert on what happens in Washington, but I don't think that we'll know what's going to come out of the meat grinder of Congress before our legislature goes home. So it'll be interesting to see what we can do. There's talk of all kinds of changes. How do we react to those changes? Because from what I can tell, some of the things will be kicked back to the states. Other things will be taken away from states potentially. We'll see what happens there. But I'm very curious to see what all we can be doing here and what our esteemed panelists will have to tell us today in terms of what may be on take for the legislature here in Montana. We have with us Senator Cary Smith, and I've got him out of order here. I know that that's not Ron Ehli sitting next to you, Cary, so I'm going to say Jessica Karjala. Is that correct? Good enough? Good. And then Representative Ron Ehli from Hamilton at the far end, and we'll just go in order of how you're sitting, if that's okay. We'll have each one present, and I know that the only thing standing between each of you and the fitness center are us, so we'll make sure that this is a timely presentation. And so with no further ado, Senator Cary Smith.
Thank you. Thank you. I appreciate this opportunity of meeting with everybody and talking a little bit about the healthcare things that we're facing in the upcoming legislative session. Just a little information about me. I worked for Sears for 32 years, so I know what the corporate world's like. I worked in Chicago. I've worked in a lot of different states and lived in a lot of different states that had different policies. I've served in the legislature now 3 terms in the House. I've served 1 session in the Senate and about to start the 2nd session. Each term I've been there, I've been on the Health and Human Services Committee, so I've gotten to know more about health care than I ever thought I would possibly get to know by just being in private life. And this upcoming session, I'm the Majority Whip, and I also will be the Vice Chair on the Health and Human Services Committee. So just to kind of balance things a little bit from what Kim Gillen said earlier, she was talking about what may happen, what's going to happen with the Affordable Health Care Act. A lot of us, it's still up in the air. We don't know, but I can tell you a couple of things for sure. When people's insurance premium rates started coming out, the polls switched dramatically from Hillary to Trump. I think people were paying attention. The Republicans up there in the federal government, from the president on everywhere down, where lots of seats were held or maintained, I should say, there's been a mantra a mantra of getting rid of Obamacare ever since it was passed, even before it passed. So the will, I think, to make changes is really great out there. And if we say, well, it's going to be business just as usual, I think we're really kidding ourselves. There's been a lot of us in the legislature that have adamantly opposed implementing any portion at all of Obamacare. And I have fought for every term that I've been there to do that. The Affordable Health Care Act was sold to us as being a method of having access to affordable health care. And it was determined that the problem was the reason why we don't have that is because not everybody's insured. So if we just get everybody insured, we'll be just fine. Well, we pretty much got everybody insured, but health care costs continue to rise. They continue to rise dramatically. The problems that we had heard about where people are losing their homes because of medical expenses, that hasn't gone down. It's gotten worse. We were told that you could keep your insurance company if you liked it. You couldn't do that. We were told you could keep your doctor if you wanted to. You couldn't do that. So just issue after issue after issue is not working with the Affordable Health Care Act. It's not affordable. It's not getting better. It's getting worse. We've had a number of insurance providers, one in Montana, leaving the exchange. That's happening in many, many states across the nation. We have lots of instances where the co-ops that were formed are going out of business. Our co-op is still here, but they're going out of business. So even without the change in administration, you see things starting to crumble. Now that the administration has changed, anybody that thinks that folks are going to feel confident about still being in the exchange, having an insurance company, still going forward, having a co-op, I don't see that happening at all. I think there's going to be more uncertainty. When it gets to talking about whether or not the Affordable Health Care Act really was affordable, we heard that 400%, if you're at 400% or below a poverty level, that you qualify for some kind of subsidy on the state exchange. And if you, so 77% of the people are getting subsidies. How can something be affordable if you have a subsidy to do it? That just doesn't make sense to me. We heard comments about, well, we're going to take care of some of the costs by, we'll take, the big corporations, they're getting a break on their taxes for providing health care, which is something that the Affordable Health Care was wanting to encourage. And now we're talking about we're going to scale those tax breaks back. That's not going to encourage the businesses to stay in it. So we're going to have fewer and fewer people that are providing health care in businesses potentially, yet we're going to give more and more people subsidies. I've been in business long enough to understand a balance sheet. And we've got more going out than we've got coming in. Now to get to some specifics, each session that I've been in the legislature, I've worked on bills that would help reform health care, that would take and use free market programs to take and try to reduce the high cost of health. Knowing that we're going to have some major shifts in what the federal government's going to do and what the state's going to do, we're starting to talk about ways that we're going to address it, how we're going to take and cover some of the holes that we have out there. One of the ways to do that is to have health care coverage programs that are outside of insurance. Now, we said that everybody needed to have health care insurance for this to work. Well, that's not really true. You have to have a means to pay for your medical expenses. It doesn't have to necessarily be insurance. Commissioner Rosendale carried a bill last session that provided for primary care physicians, and what the idea on that is that you set up an arrangement with a physician to have some of your basic needs taken. Maybe you pay $50 a month, $100 a month, but the more or less out-of-pocket expenses that aren't real high are taken care of. Emergency things aren't taken care of, and major medical things aren't taken care of. But the stuff like the flu shots, the well baby checkups, those kinds of things are covered. That particular bill was vetoed last session, but we think, and one of the reasons why the governor vetoed it, he said, well, you're already covered with that if you have an insurance policy, because we mandate everything be covered. Well, that's not necessarily true, but knowing that the Affordable Health Care Act is going by the wayside, there's another reason to take and do this. We also have a bill that I've introduced a couple of times that works with healthcare sharing ministries, and that's where people of faith join together to take and pay healthcare costs. Much less of a cost than you have with insurance. Again, that's going outside the insurance, but the insurance is one of the high costs of health care. When you're a legislator, we have close to $10,000 a year that all you taxpayers are paying for my health care insurance. $10,000. And I put another $250 a month into it. That's a huge amount of money. We're looking at that. If I didn't belong to the state insurance program and was getting coverage for my wife and me through a healthcare sharing ministry, our monthly premium would be closer to $350, $400. And they do cover your healthcare expenses. So you can see the savings right there. Now, that's not even an alternative for us with the state health plan. We have to have the same plan that is a one-size-fits-all. When you talk about encouraging health savings accounts, that's one of the things we hear about all the time on the national level. I've had bills that would give a subsidy to you or a tax credit and encourage you to set up a health savings account with a high deductible. That's another way to take and bring down the high cost of health care, because now you're just paying for more or less major medical type issues, but it also gives you a reason to want to shop around, because that out-of-pocket expense that you're taking out of your health savings account, you want to make that last as long as you can. We've had those bills vetoed, but that's also being talked about on the national level. It's a good idea. It helps people to get insured. It helps make insurance affordable. One of the other things that we need to look at that has gone away with the Affordable Health Care Act, we used to have a program called Insure Montana, where the state helped to subsidize small businesses to cover health insurance. We extended Insure Montana for 1 year after the Affordable Health Care Act came out because the small shop program wasn't up and running. We looked at extending that last session, because we found out that a lot of small businesses that had Insure Montana did not like the small shop. It didn't cover employees' dependents, so it was not popular. We tried to go back and extend Insure Montana for another session because we knew it was helping people. With Obamacare going away, the small shop goes away also. The high risk pool was mentioned by the previous panel in the discussions. The high risk pool is where we take people that are really, really, really hard to insure, and we make it more possible for them to get insurance. Montana had a high risk pool, and that went away because the Affordable Health Care Act took that over. Now, there were several years of the Affordable Health Care Act where they ran out of money by midsummer, but that's going to leave a hole in the program. There has been talk about insurance across state lines. I've carried bills for several sessions that allows you to buy insurance across state lines. And why that becomes such a popular notion is that because it was mentioned earlier that we need to have our insurance commissioner protect us, make the decisions for us on what kind of health care we have. And a lot of the times the insurance commissioners think that because we're not smart enough to make those decisions ourselves. But the reality is, if I wanted to buy in a policy from Idaho, I trust the government in Idaho. I've lived in Idaho. And they have more affordable insurance than we do here because they don't have as many mandates. Yet in Montana, and with the Affordable Health Care Act, we've decided that if you're going to have health insurance, you have to have a whole bunch of stuff covered. We think we have either 41 or 42 mandates in Montana. With the Affordable Health Care Act, they came out with what they call essential health care mandates, and a lot of those deal with women's reproductive issues. Now, I got to tell you, I understand the importance of having babies. I've got 30 grandkids. I've got 6 kids, so I understand what it's like to have kids and have women's concerns about how we take care of health care. But my wife and I are now in our mid-60s, and we don't need maternity coverage. One of the reasons why we can't get the healthy invincibles to buy health insurance is because we're concerned, because we try to make them have insurance policies that would cover things that they're not concerned with. Our young invincibles are mostly concerned about accidents. That's the most common problem they have. But if they're single, they're not worried about maternity care. If they're young, they're not worried about diabetes. They're not worried about health disease. They're not worried about a lot of the things we've talked about that maybe they should be worried about, but they don't have those diseases. And another part of the Affordable Health Care Act that we take and try to trump up saying this is really, really, really a great issue is when we talked about you can now have your older kids up till they're 26 covered on your insurance policy. Well, that's whoopee-doo. Those kids don't get sick anyway. So that's not really a big benefit. But we would like them to have insurance because we don't want them to break a leg and not be able to afford it, because that can be expensive now. Or probably most common, we talked about ACL surgeries and the transparency and all that. That's what my kids seem to have problems with, or issues like that. Another thing that we talked about in the affordable health care, and the reason why to keep that, was pre-existing conditions. And I think we heard something like 100 million people now can get insurance, or somewhere around there at 150 million, that couldn't get insurance because of pre-existing conditions. I want to kind of clear the air on pre-existing conditions. If you had a group health care policy, like I did the whole time I was at Sears, they could not deny you pre-existing conditions. They may be able to tell to you, well, we're not going to cover it for a month or 2 months, but you had pre-existing conditions covered. The people that didn't have pre-existing conditions covered were those that were trying to buy individual policies out there. So, let's not talk about what a great benefit it is now to have your kid covered till they're 27. That didn't cost that much anyway. And pre-existing conditions, we certainly could have solved that problem without going through all the gyrations we did in totally changing the health care program. We talked about how the people that are opposed to the Affordable Health Care Act don't have a comprehensive program to cover everything. In the state of Montana, I don't like comprehensive programs. I don't create bills, or I don't work on bills that solve every problem we have. They're too complicated, they're too hard to pass, they're too hard to deal with, you have too many roadblocks that are set up. That's the problem with the Affordable Health Care. You tried to take and create something that just about everybody would be happy with. It got so complicated that people that wrote it don't even know what's in it. And we're still having some of those problems coming from there. So again, the bills I've been talking about that are directed towards individual issues are things that can be passed, that things that can stand on their own, that won't get killed because there's another part of the bill that some...
May I have your attention, please? A false alarm has sounded on the 11th floor. There is no cause for concern. This was a false alarm. We apologize for the inconvenience. Thank you.
Okay.
May I have your attention, please? A false alarm has sounded on the 11th floor. There is no cause for concern. This was a false alarm. We apologize for the inconvenience. Thank you.
That false alarm is not in reference to my comments. The affordable health care is going to go away. It's going to have some major changes to it. There's been a lot of talk about transparency, to get back to things that we can specifically do in the legislature. But before I get to that, I just looked over at Ron and thought about another thing too. During the last session, the House had some really great bills that would have covered some of our health care problems, some of the people that were falling through the cracks. And the argument that we tried to make in the legislature was, we don't really have a lot of confidence that at that time they were still ruling on whether or not the states were going to be subsidized, whether or not you had a state exchange or you had a federal exchange. There were other issues where we had some real concerns about how are we going to fund this in the future if we run out of money, if the administration changes, if the Affordable Health Care Act doesn't go into forever. So we had some programs that would have been funded more by the state that would have taken care of a lot of these problems, but unfortunately those didn't get passed. So now we're looking at the reality of, okay, Affordable Health Care Act on the way act, and we didn't get stuff passed last time that we needed to, so now we need to look at it this session. There was a lot of talk about transparency with the previous group. I was elected to the legislature in 2008. The first bill that I had passed was the Right to Know bill. So that bill that we were talking about that's in Montana law is a bill that I carried and got passed. So I've been involved in this issue for a long time. When I, as a freshman legislator and being very naive, when I first showed up with that bill, I got a call from one of the other representatives, and they said, everybody in the industry is going to oppose your bill. The insurance companies, the health providers, they're all going to come out and give reasons why they can't do that. So I said, okay, well, let's get together with those folks, and we talked about it. And the bill was much more comprehensive, much stricter than it ended up being. And when the bill finally passed, I didn't have a single opponent, and I think all but maybe 3 legislators voted for the bill. But even back then, in 2009, it was very evident that we needed transparency. What the lobbyists, what the folks that didn't like the bill the way it started out said, just give us some time. Give us some time. We're gonna work on this. We're gonna get the health care costs down. They were producing some websites that gave you some transparency. They were talking about it, but it was more kind of a volunteer type thing. And by the way, from what we heard from Cary, there are folks in the healthcare industry right now that are violating state law if they can't give you a good faith estimate. So, I guess that's how much they're concerned about the law. Either they don't know about it or they don't really care about it. So what we find out, the reason why the transparency, even though it may be out there, the problem is, what's the incentive to the consumer to actually go shop? Now, each kind of insurance that you have is a little bit different. You have preferred providers, and you have self-insured organizations that Cary was talking about that do some of this to get their people to shop. But the average consumer is like the person that she was talking about that was going to get the ear implant, and they paid $60,000, and they didn't really care because what it was going to cost was going to be about the same anywhere they went, so no reason to shop. People don't shop. People don't take control of their own health needs because we have decided as government, we have decided as insurance companies, as we have decided by state insurance commissioners, as we've decided by the healthcare providers, we all know better what you need for your health care than you do. We'll tell you what kind of policy you have. We'll tell you where to go. We'll tell you how long you're going to stay there, and we're going to tell you what you're going to pay. And so we have a lot of instances where the consumer has abdicated a lot of responsibility, but they're not really concerned about it anyway because their out-of-pocket expense probably isn't going to be any different. Attending a lot of meetings this past year, we keep hearing the silver bullet to correcting the high cost of health care is if we could just get transparency. We need transparency. There is a lot of transparency out there. It may not be as comprehensive as we would like. It may not tell us as much as we'd like to know, like the outcomes. It may be based on information that is kind of faulty, as we heard, that just based upon your reputation, that's going to say whether or not you're a good healthcare provider. So, but there is transparency, and we need to take it and improve the transparency. What we really need to work on is what is the incentive for the consumer to take and shop. We need to get the consumer to be concerned about what they're doing. We talked a lot in the last session about we have to have consumers realize they got to live healthy lifestyles, and they got to go see the doctor annually, and they got to do all these things and these things and these things. We've been preaching that for a long time, and you know what? They still don't do it very well. But it's something we need to keep talking about. But when you start talking about money that's being spent, that is a really big, different issue. I see public service announcements on the TV all the time that say you as a consumer need to know that if you've been in an automobile accident, you can take your car anywhere you want to get your repair. The insurance company can't tell you where you're going to go. Yet when it comes to health insurance, we say be aware that your insurance company can tell you exactly where you're going to go. That doesn't seem right to me. We need to take a different look at that. So the bill I have, it's already been written, follows along with the right to know bill, and I call this the right to shop bill. And it's been written, and it's going to be introduced by me in the legislature, and I'm looking for support on it. And I think this will be making a big difference to what's going on. And this bill is needed whether or not you get rid of the Affordable Health Care Act, whether you have a single payer or you have a totally free market. You still need to get the health care down. Then the last thing I wanted to talk about that was just mentioned a little bit by Steve, I think. We have moved to what is a very socialistic type handling of our health care in the United States. Yet of all the countries that have been on a socialist type health care program, we are still the most expensive. We can't even do programs like that as good as Canada, England can. And one of the major differences is that was just talked briefly about it, but I want you to really think about it. It's our high cost of litigation in the United States. There's only a couple of places where litigation takes place like it does. I think Israel and the United States are a couple of them. So we have to seriously look at tort reform. I have carried tort reform bills in the past too. We had a very comprehensive group of tort reform bills, I think in the 2011 and the 2013 session, to take and try to address this. When you've got something that's a third of your total health care costs, that you're about the only nation in the world that doesn't address that, regardless of what kind of a program you have, whether it's the Affordable Health Care Act, a free market, or a single payer, we're never going to have our health care expenses in line with the rest of the country. So that's something we have to look at again. And those bills have been vetoed by our previous governors. I think it's time to start talking about that again. Those are some of the things that we're looking at, and things come up daily. I keep in contact with people in Washington and people in think tanks to find out what's happening, what we can do, what we can't do. We have to be on our toes. We may have to come back into a special session. One of the things that I'm concerned about with the talk that we hear about insurance across state lines, I think I've heard the president-elect say something, or one of his surrogates say, well, why shouldn't you be able to buy insurance across the state line if they're willing to adhere to all the states and to all the laws in the state of Montana? Well, that sounds good, but that's really not what we want. I don't want to buy insurance that's going to adhere to all of the mandates in Montana, which is part of our law, because that's what makes it so expensive. As long as we have to tell people in Montana what kind of insurance they're going to have, based upon what we pass through the legislature with insurance mandates or what the insurance commissioner believes, our insurance is still going to be higher than states with fewer mandates. So the availability of having somebody with an insurance carrier in another state, just following what we do in Montana, doesn't introduce the free market aspects that we would really like to have. So I think it's important for us to get out ahead of some of these issues and make sure that if we're going to be able to buy insurance across state lines, it really does benefit us so that we can have more of a free market. You can buy insurance cheaper in Wyoming that has a smaller population than we do in Montana. So it just doesn't work on talking about the pool either. So these are some of the things we're looking at during the question and answer period. I'd be happy to answer anything. But again, like Kim, I don't have the little ball to twirl around up here, but a lot of the things are, I don't know. We'll have to see what's going to happen. How fast are they going to move? But I do know things are going to change, and we need to be able to take and make those changes if necessary. If we're going to have, for instance, something like we had Medicaid expansion, and let's say, okay, the government, the federal government's not going to pay for that 99% or whatever it is of the cost of Medicaid expansion. What are we going to do? In case you haven't looked, the coffers are looking a little light for this next session coming up. And even though we talk about revenues being down from taxes and from business and from the price of commodities that's taken place in Montana, close to 44% of our revenue comes from the federal government. If we've got a federal government that says we spend too much and we're going to spend less, you got to take and ask the question, what's going to happen to 44% of our revenue? That's our biggest single source of money, and I think it's about to change. So let's be ready. Thank you.
So for some of you that know me, you know that I'm not a healthcare expert. I don't come from a medical background. Some of you have heard me present legislation. You've heard me talk about my grandfather. My mother's father had muscular dystrophy. He taught high school biology, and as a result of his muscular dystrophy, he became so disabled that he had to quit working. As a result, my grandmother had to go back to school. She went and got a nursing degree. And on her nurse's salary, she had to support a husband and 5 kids. She also provided his in-home care because they didn't have insurance. Understanding this from a generational perspective, seeing the hardships that a disability like this can cause a family, I look at it from perhaps more consumer side or more from the human services side. I didn't embellish my resume too much on this, I see, but I should also talk about that a little bit too, because the reason that I went into work helping folks with disabilities was absolutely because of my grandfather, but also because of my dad's brother who has a developmental disability. When you grow up with family who have disability issues, you understand things from the consumer side, and you also see things from the insurance side and the reimbursement side. like we've been hearing today, that like from Mr. Lovelace, that when the compensation rates or the reimbursement rates coming from, say, maybe Medicare or from Medicaid are not quite cutting it, and that the hospital has to come up with some way to keep, their operations going. You can look at it from the perspective that, it could be about money, it could be about budgets, but it's also about people. So one of the things that I did before I became a legislator was that I worked as an advocate for folks with disabilities. And that could involve anything from helping folks from applying for disability benefits. It could involve maybe helping folks find services. A lot of the times I say what I did was, if it was a fire, it hit my desk. So when vocational rehabilitation couldn't deal with it, or when another human services provider couldn't deal with it, it inevitably came to me, and I saw cases that involved termination of Medicaid benefits. One young man's parents came in to me when his Medicaid had just been abruptly cut off. Well, of course, he'd been receiving notices from Social Security Administration, but this young man had a vision impairment. He had had his pituitary gland removed due to a malignant tumor. So he had to take medication every day to replace the functions that the pituitary gland did. These medications cost into the tens of thousands of dollars. When the mom hit my office, she was beside herself. She was panicked. And the first thing that happened when I got back to them with a follow-up was that I told her, well, it also looks like you have a case of recoupment. They wanted to go back and ask that he repay 7 years' worth of cash benefits also. So rather than looking like we were going to make any progress on the case, it got worse. What we realized after a period of investigation was that due to participation in a vocational rehabilitation program, this young man's benefits had been terminated retroactively. His Medicaid had been cut off, and that he was now in a situation where he didn't have any medical coverage or any cash benefits and was facing some debt. I was able to go in and investigate, determine where the problem had originated. We were able to resolve it. It ended up with a happy ending, but not all cases end up that way. We can't allow to look at things just from a dollars and cents perspective, and I really appreciated Steve Lovelace talking about it from the provider's side. One of the stories that he talked about was also the elderly woman that had been left at the hospital, abandoned for lack of a better term. I know that this is a growing problem, and that is one of the things that our interim committee dealt with. We talked about how we could overcome some of these challenges. Some of this came from the Guardianship Council, and what they proposed and what we came up with as a legislative solution to some of this was a process of stakeholders coming together and addressing a problem where folks were left in situations where it did become a life and death situation, where elderly indigent folks were being left at the hospitals were being left with how to find care for these folks. And what we realized through hearings and from the folks that were having to deal with these folks that had been abandoned was that they were lacking guardianship services. So we have come up with LC 281. It's called the WINGS bill, or the WINGS Group and Grant Program. It's an acronym for Working Interdisciplinary Network of Guardianship Stakeholders. Essentially, what it will provide is, in an instance where an elderly person might be abandoned on the steps of the hospital, we'll be able to come up with guardianship services for persons in those instances. We'll also be able to come up with guardianship services for, say, maybe a disabled person who is also in need of guardianship services, who doesn't have a family member or anyone else who would step forward to provide those services. And why that's important from a dollars and cents perspective, then you're looking at somebody who's able to be able to make those decisions for their health care. They'll be able to get them insurance, perhaps they'll be able to get them care provision, and then it doesn't end up being uncompensated care that gets passed on to the hospitals that ultimately gets passed on to us. The reason that I think that this is brilliant is because it addresses both a social problem, a growing social problem, but it also addresses the economic situation, the growing situation of uncompensated care. The other part of the Wings bill will include a 9-member network that will include members from the court, from DPHHS and Adult Protective Services, from advocacy groups, from who do advocacy for folks with disabilities. We'll also have a representative from senior citizens groups and professional guardianship, somebody from the state bar. Sorry, I'm having trouble reading my own handwriting. And also someone from the Guardianship Council. When we work on legislation like this, I know Steve said he doesn't like the idea of legislative solutions to some of these problems, but when they come to us from the stakeholder groups, when they come to us from the providers, and they've talked to other folks with this, when we put them through a process like an interim committee, we can vet these bills really, really well, and we do come up with a solution that everybody can get behind. Hopefully, this bill will end up getting widespread support through the legislature, and what is it, 80% of our interim committee bills end up passing. I'm sure hoping that this bill will pass because it provides a socioeconomic solution to a growing problem. One of the other issues that we addressed as a whole, and yes, this is a segue into your part of this, Ron, is looking at aging-related diseases. So when we're looking at socioeconomic impact on insurance, growing medical costs, we need to look at the silver tsunami, the aging of the American population, and Montana is one of those states that has one of the larger percentages of elderly people, and so I was really proud to work on this committee where we addressed this issue. It is a growing problem, and I'm proud to say that with our committee, it's a bipartisan committee composed of members from both the Senate and the House. I don't think there were many issues, if there were any, that we disagreed on, and as a result, we were able to come up with some really fantastic legislation, and with that, I'll let Ron talk about some of the rest of those bills.
That was a very good lead-in, Jessica. I appreciate that. My name is Ron Ehli. I'm from House District 86 over in Hamilton, Montana. I guess Montana, we know that. But traveled over here this morning. My wife was a little concerned about me headed this way. And she said, you're going to Billings? I said, yeah. She said, well, it's supposed to be snowing all along the way. And I said, okay, well, we're from Montana. We can handle this. And so headed out this morning and got to Butte. And she called me and says, well, what's it doing in Butte? And I said, oh, it's snowing, but it's okay. We'll just keep going. And got to Bozeman, and she said, well, what's it doing in Bozeman? I said, well, it's snowing, but it's okay. We'll just keep going. All is well. And I got to Billings. She said, well, what's it doing in Billings? And I said, well, I think it's snowing, but it's blowing east, so it's landing somewhere else. I say that because I grew up in eastern Montana. I grew up in Circle, and God, the further you go east, the more the wind blows for sure. But that was the case always when I was growing up, is if it was snowing in Circle, it was landing in Glendive, and all was well. So a little introduction about myself. I come from, I'll be a fourth-term legislator. I was on Appropriations Subcommittee for Health and Human Services. I was chairman for the last 2 sessions, and I was chosen as chairman 2 sessions ago, and it was one of those situations where I had no idea. You know, DPHHS, I went into staff very first thing. Some of you that have heard me say this before, I didn't even know what it stood for. Department of Public Health and Human Services. Okay, well, I'll write that down. We'll figure that out later. And that's where I started this. I had no intention to be part of Health and Human Services in my legislative career, but that's where I ended up, and it's the best thing that's ever happened to me ever. It brought me to another level of passion, which is where I speak from when I get up in front of people. So I don't want to get into specifics. I want to get into some 10,000-foot level legislative things, because this is about what's going to happen in the legislature. But I'll touch on some of the bills that, as Jessica talked about, we did some really good work in the interim. I was fortunate enough to chair that interim committee for Health and Human Services and worked on a bipartisan to get a lot of good legislation that's going to come forward. So one of the things that we focused on in this interim cycle was Health and Human Services for the aging population. Now, when you talk about Health and Human Services in the legislative, especially the last two legislative sessions, this is going to come as a surprise that not all Health and Human Services issues are related to Obamacare or Medicaid expansion. So anytime we get into that discussion, it's always about Medicaid expansion. Now, nobody's better at that than Senator Cary Smith, but we have to go beyond that discussion at some point in time, although I can't tell you there's nothing more important, but I want to touch on some different things today. So one of the issues that we had going into the interim is to understand the aging population. Last interim, we talked a lot about mental health. We established some good bills in the legislature, and they're going forward, and they'll be refunded this year. So we'll continue to work on those issues for mental illness. But we've got more vulnerable populations that we have to continue to talk about. We have to talk about the aging population in Montana. In 10 years, 42% of the people are going to have issues with aging in the state of Montana. We have to talk about those with developmentally disabled, and of course we're going to continue to talk about those with mental health issues in the state of Montana. And the reason I want to talk about this from the 10,000 foot level is because as we move towards this legislative session, Senator Smith alluded to it about the dollars and the tight budget. And one of the things that are coming out of this legislative session that we're going to be offering up out of the interim committee are bills that are going to take some dollars to get passed. They're going to take some funding from the state legislature. And so the quickest answer that we received coming out is forget about it. There's no money. And I said, that's just not going to pass. I'm not going to stand for that. This budget that we deal with on a biennial basis is $10.5 billion. Nobody can tell me that there's not money for the vulnerable populations in the state of Montana. So if there isn't any extra money, then we're going to go look about reprioritizing the dollars that are available to us at a legislative level. And so that's going to be tough, and I guess the message going into it is buckle up. It's going to be a bumpy ride, and I believe it is. But I think that's what we're there for. We're there to answer the tough questions. We're there to fight for the dollars for those that you're passionate about, and that's one of the areas that I am. So when you start talking, I guess I'll touch a little bit about some of the bills that Representative Karjala talked on, but we're coming out with some bills to increase home and community-based services waivers, and there was over 500 people on a waiting list, and that's grown. And so we have a bill that's going to take, hopefully, we can take care of about 200 of those people that are on that waiting list, only that many, 200 slots. And we're also going to take a look at increasing the reimbursement rates for some of the Medicaid for the aging populations. Those with Alzheimer and dementia cost more to take care of those, and our providers out in the communities are drowning. They're drowning trying to keep up with the costs of taking care of our aging populations in general. So we want to take a look at that. Some of the conversations before about let's not look at cost alone. I agree with that. I agree that we can't look at cost alone, but it's a very, very important factor. As we take a look at currently, the budget for Health and Human Services in the state of Montana takes up 42%. 42% of the state budget goes to Health and Human Services. If we don't take a look at those costs, if we don't start finding the best way to take care of our vulnerable populations, meaning those with mental health, those developmentally disabled, those aging populations that are coming our way, then we're going to run into a terrible situation with budget. You're never going to be able to make ends meet. So the drive is not a drive to the bottom with cost. The drive is finding the most efficient and effective way to get care to these people. And one of my passions that I became adamant about as a legislator years ago is how do we get those back? How do we get those costs and those people and the services that we need back to the communities? That's the best place to do services, in the communities. We had the presentation from Steve before was, community-based care versus acute care. The further you go up the ladder, the more it costs. It's the communities that can provide the services the most efficient and effective way. And so all legislation that we've been looking at all through the interim and in the last session was about how we can bring those costs back to the communities. That's where your tax dollars come from. That's where they should go back to service those people in need. So again, at 10,000-foot level, some of the other bills that we're looking at to help with the mental health issues from the last session was, as people with mental illness come out of Montana State Hospital or even out of prison, they get back to their communities and they don't have access to their medications. So one of the things we're going to look at is a pharmacist bill where the pharmacist can dispense and manage the drug therapy that needs to be done for these people in the community. Currently, that's not allowed in Montana Medicaid, so it's something that we're going to try to take a look at and see if we can provide those rural communities in Circle, Montana, some opportunities to take care of those people that need help. I think Jessica touched on Area Agency on Aging and grant programs for volunteer respite training. Again, programs back in the community, granting dollars to those organizations, those providers that can help with respite training, helping to take care of our aging populations back home. And finally, one of the bills that came out from the interim was protection for vulnerable persons from financial exploitation. So just a bill where there's so many of our, again, looking at the tsunami of aging populations that are coming, how do we take care of, how do we protect those people and protect their life savings? There is some exploitation out there, and we want to make sure that that isn't going to continue, and those financial wherewithal for all the aging populations is protected. So going back to the legislative session, how are we going to do this? We talked a lot about prioritizing of the dollars, and that's going to be a struggle. There's a difference of opinion as how we're going to spend money. Of course, we get a governor's budget to look at, and we get to take a look at that, and we get to challenge those dollars. So when there is zero extra dollars to be spent, what do you start talking about prioritizing? Well, from my perspective, we've got to get back to basics. We've got to get back to the basics of what we're supposed to be doing as a state government. We're supposed to be taking care of the most basic needs of people. That's a belief that I have. When I take a look at budgets that are trying to add programs or expand programs, especially at a time like this when budget dollars are really tight, that's going to be the challenge for me, to challenge those programs to see why we're not spending money on the basics of what Montana needs. And I say that because if you're coming from appropriation, in the last two sessions, we started the sessions with over $500 million of budget excess. And we did very little for those populations that I'm talking about. So if we can't get help to the most vulnerable populations when we're running $500 million budget surpluses, how are we ever going to do it when we're in a budget constraint year like we're going to be in now? And my answer to that is, we're going to find a way. We've got to find a way, because it's a matter of prioritization. Because if you're not going to find it when you're running huge budget surpluses, how are you going to find it when you don't? So the answer to me is I think we got to change priorities and figure out how we're going to take care of these people. So we talked about the dollars and the 10,000-foot level. That's where I'm going to leave this conversation. It's going to be a tough legislative year. There's going to be some great discussions, and I think bipartisan discussions. Representative Karjala talked about how great we worked together in that interim because we understood the needs of the people of Montana. And we got to get back to those basics. We got to take care of those most needy. I think that's what we're all about. So 10,000 foot level, I'm going to step out, and hopefully there's some questions you guys can ask or some specifics that you might want to talk about, and be happy to answer those questions. Thank you.
I think, Kelly, do you have the microphone? Great. All right. So any questions for our panelists? Don't hold back. Oh, there we go. Good.
Representatives and Senator, thanks for your service to us Montanans and the work you've done over the last couple sessions. Dan Awney, Mental Health America, Montana. One of my concerns is always that when we talk about short dollars is that we look at the business of government, like you had offered, Representative Ehli, that we have the largest Department of Public Health and Human Services, and I'm not sure that serves Montanans having this big corporate organization with little accountability to chase back activities that happen. And I'm wondering, rather than more bills getting created, could there be a way that we could look at it and look for efficiencies to drive those dollars that we save back into services?
Yeah, so I could, and thank you for the question, Mr. Awney. I appreciate that. And I think I understand what you're trying to do is accountability within a budget. So if you're talking about a health and human services budget, again, that accounts for 42% of the state budget, why is that never a question in a political arena? You know, so I'm going to tell you the answer to that is because it's huge, it's confusing, it's difficult, and nobody wants to talk about it. Well, it's only a matter of time until we do have to talk about it. So introducing more bills, the bills that I hope that you see being introduced are bills of efficiency that we're trying to get to that point. There's a lot of discussion at the level, my good friend Director Opper, we've had the discussion about accountability and trying to figure out where the dollars are being spent and trying to get back to making those most efficient of all. But you know, it's a tough question when you're talking about government, and how do we come to grips with the fact that we're spending all of these dollars on health and human services for the right reasons, they're going to the right place, but are they being used the most efficient way? So I don't know really how to answer your question other than I'll tell you this, that every bill that comes forward and has come forward in the last two sessions and the discussions that are happening from good folks that are in this room that come and testify are about efficiencies. And how do we continue to drive that way? No easy answers when you're talking about government, but I don't think it should ever stop that discussion.
Thank you, Mr. Awney, for the question. I think when we're talking about the Department of Health and Human Services, you need to remember that we're not just talking about one per se agency. They're not only overseeing the medical community delivery of healthcare services, but they're also overseeing human services provision. A lot of those agencies are nonprofit agencies. They're also administrating a lot of the programs that come from federal funds. And so when we look at the breakdown of the budget, there are a lot of federal matches, there are a lot of federally funded programs, and in terms of inefficiencies, or maybe even when we're going to talk about fraud, Montana has one of the lowest rates of Medicaid fraud in the nation. And in terms of efficiencies, you know, we do have audits, we have legislative audits. I think that when we talk about the budget of the Department of Health and Human Services, we need to look at it in scope, and when we're talking about delivery of services to every single person in the state, whether or not they're a taxpayer or not, and a lot of them are not, of course that's going to be the largest portion of your budget. It only makes sense.
Can I address that also?
Please, yes.
You know, we're talking about the Department of Health and Human Services and how we can be more efficient on our expenses. I've carried bills that would have, the most recent one simply just made a check that was done by a third-party company, so we weren't self-auditing ourselves in the Department of Health and Human Services. We had a third party checking just to make sure that folks that were getting Medicare, Medicaid, SNAP, CHIPS, any federal program actually qualified for the program. And it was modeled on not a red Republican state. I modeled it on Illinois. Illinois had got themselves in a position where they just couldn't afford their services anymore. They ran out of money. Fortunately, Montana has had surplus money most of the sessions I've served, so we don't worry as much about it. But we actually had whistleblowers come to us, and they came to some of the hearings that Ron had, and we've got some lawsuits going on in the state right now where whistleblowers have come out and said, you know, the Department of Health and Human Services is not handling the federal money the way they should be. So that's a problem to us all as taxpayers, and it also makes it so that when Representative Ehli is talking about we have people that would normally qualify for Medicare, but they don't because we're spending Medicare money somewhere else, potentially somewhere where we shouldn't be, or fraudulently, and we don't have the willpower to go and even check that. You know, I heard a comment that we're one of the lowest for any fraud taking place. That statistics they come out on Medicare is really, really, really a small sampling. And the audits that we have, the audits within the state, have shown there are some problems there. So it is definitely a place that we need to check because we're not spending the money wisely. And when you've got a budget as large as that is, and we talk about Medicaid fraud, that, you know, they were going to pay for the Affordable Health Care Act by going after the fraud. Well, it hasn't happened at the state level, and it hasn't happened at the federal level, and it still continues to take place. So we want to make sure that people that really qualify for benefits, the ones that are really needy in the state, like Representative Ehli said, are helped, that we do take care of those folks, but there's no sense in taking care of somebody that really could be taking care of themselves and they don't qualify for the programs.
Thank you. Mr. Lottie.
Bruce Lottie, Pipe Trades Trust. One of the things that I've encountered recently has been a great deal of time that I've spent adjudicating claims that have to do with medical transportation. And I know that the legislature had some hearings recently with regard to how to deal with that whole unregulated area of medical transportation. Is there any bills that came out of that or any legislative action that you're contemplating?
I know just a little bit about it. You're right, there is some concern about that. We've had studies taking place over the interim. I think Senator Gordy Vance is going to carry a bill on that. The dilemma becomes, we're told that because it's airplanes, that's something the federal government regulates. We don't necessarily believe that's true. I think in the state of Montana, we have to quit taking the attitude, well, the federal government's in charge of that. Because the federal government doesn't do a lot of things very well. And anytime we turn things over to them, we're looking for things to be expensive. So I can't tell you a lot about what's taking place other than we've got a couple of carriers in the state that are really bad. We've got a lot of carriers that are really good. And some legislation is being looked, and if you wanted to know more about it, I'd give Gordy Vance a call.
Representative Karjala.
Thank you. Can I take the liberty of having someone else answer this question because I doubt there's anybody else in the room that knows more about it than Commissioner Lundeen? Oh, and I don't mean to put you on the spot, but if there's somebody else that knows about it, my apologies.
Yeah, you're probably right.
Thanks, Representative. Actually, there is somebody who knows a lot more than me. He's just not here today. I would just say that it is true that we have no ability to regulate those air flight or health flight businesses at this point in time. There are some things that we've been working on with the legislators to try to come up with some things that we can do, but there's also legislation at the federal level that they're working on. Right now, they're actually studying the issue, which we think is not a good solution. We would really like them to pass the act at the federal level to give the states the ability to regulate at this level. And so I would suggest that you talk to our congressional delegation about making sure that they are supporting that. So that's what I have to add to the conversation.
Other questions? We have time for one or two more. Well, seeing none. Oh, wait, we do have one. Please.
Hi, I'm Emma Carpenter from Youth Dynamics. I'm just wondering to what extent, as you guys are considering some of the legislation you're considering this session around services for elderly, to what extent some of that will also be crossing over into the realm of developmental disability and disability legislation.
Representative Karjala?
Thank you for the question. The Wings bill will definitely be providing some type of assistance to organizations that provide services to folks with disabilities in terms of being able to set up guardianships for indigent folks. The home and community-based service waivers will also hopefully be able to provide some services, and also the oversight over the financial oversight over financial exploitation bill will also provide protections for people with disabilities who may have a conservatorship or may have a guardianship, and I'd be glad to answer more questions on that later if you have them.
Other responses? No. Well, don't go anywhere. Tanya is going to close us up for the evening, but let's give one round of applause for our panelists.
I would like to add my thanks, and I appreciate the question, also acknowledging the service, because anybody who runs for public office and serves is truly a public servant. So thank you on behalf of everybody here, not only for your service, but also for answering the questions that we have, and we look forward to seeing what does come of the session.